Hello, I'm Lyndon Cooper, and I'm the Associate Dean for Research at the UIC College of Dentistry. I've spent the last 20 to 25 years studying implant osseointegration and have begun to consider more broadly how we achieve success on a day-to-day basis clinically. I'd like to introduce you to the bone care concept. We can consider bone care as assuring bone formation, remodeling, and related dental implant success that contributes to oral health. What is bone care? Well, it's a spectrum of activities that we use in the treatment of a patient who receives dental implants that begins with diagnosis. We consider the local and systemic factors that affect implant success. It continues with therapeutics, which includes regeneration of bone, the augmentation of bone, and of course, the core, the osseointegration of dental implants in that bone. And it doesn't end for the lifetime of the dental implant. It involves the maintenance, professional and home care maintenance of the dental implant for the lifetime of the patient to assure that we have the appropriate occlusal forces and appropriate inflammatory conditions to assure lifelong success of the dental implant. Bone care has a very specific appearance. When successful, bone care preserves implant bone interface. If we look at a study that we conducted comparing different implant designs and their ability to deliver bone care, we can see that the conus interface implants with MicroThreads and the OsseoSpeed surface achieves approximately 95% success as measured by less than 0.5 millimeters of bone loss over 5 years. Importantly, you can see there are no implants in this study of over 150 implants that lost more than 1 millimeter of bone. In contrast, the other comparator implants demonstrate very few implants that achieve this 5-year success rate. You'll notice we're comparing 93% to 24 or 46% success. But those averages may not be important. What's important are what I mark as outliers. And while I might be willing to accept 1 or 2 millimeters of bone loss at a dental implant, and certainly wouldn't consider that the hallmark of implant failure, if my practice is attaining implants that have, as you see for the one implant, the flat top implant, approximately 10% of the implants have more than 2 millimeters of bone loss, and this platform switch design implant has approximately 20% of the implants with more than 2 millimeters of bone loss, I'm acquiring more risk in my practice than I would like. That does not represent bone care. In another study by Michael Norton, this meta-analysis of a large number of implants looking at this Astra Tech implant design versus an SLA implant or the Straumann implant and the Nobel Biocare implants revealed that there was a remarkable difference, again, in the marginal bone losses. Again, looking much like the study we've presented, this OsseoSpeed surfaced implant design seems to be associated with the preservation of marginal bone over the long period of time. Very different than what we see for other implants. It appears to us that it is the implant design that contributes to bone care. Thinking about 2,500 implants in Michael Norton's study, you would consider that there seems to be an averaging of hygiene factors, age factors, local factors, and the real difference here has to be the implant design. We know that macro design influences implant insertion to assure primary stability in bone care. We know that the surface topography is essential to assuring osseoinduction in bone formation that assures secondary stability of the implant. And we know from our studies and many others that the implant abutment interface and the crestal thread design influences crestal tissue responses to assure bone maintenance. Primary stability, secondary stability, and the assurance of bone maintenance are hallmarks of bone care. OsseoSpeed is the benchmark for osteoinduction. Human data demonstrates that accelerated bone formation occurs at this implant surface. This is well represented by a study by Clark Stanford and Raina Barwell that demonstrated that the loss of primary stability, or the reduction of primary stability that occurs early following implant placement, is rapidly regained, and very rapidly regained in type 3 and type 4 bone at this implant surface. And our team demonstrated in a molecular study of bone formation at implants in humans that the genes responsible for causing bone formation at the implant surfaces are upregulated twofold when we compared the OsseoSpeed surface to its predicate tioblast surface. Thus, OsseoSpeed is essential for the rapid formation of bone, leading to strong secondary stability. Today, a new implant design, PrimeTaper, is being introduced, and it presents with a different macro design. It is a tapered progressive thread implant design that has 3 types of threads to assure for primary stability. The first are cutting threads that enhance mechanical bone anchorage in cases of bone density. The second are condensing threads, which evenly distribute stress and hold the implant in place while the implant itself is rapidly gaining new bone after the implant has been placed. This contributes more to the primary stability. And then third are the conserving threads we know so well. We know that microthreads are more effective in reducing stress, that they are very good at distributing angled loads, and it's been proven, as I showed earlier, that microthreads are associated with the reduction of marginal bone loss. Together, cutting, condensing, and conserving threads displayed on a tapered implant of progressive thread design lead to an implant that can assure the clinician of excellent clinical handling characteristics as well as assurances of gaining primary stability. As an example of comparing the new PrimeTaper design to the existing EV design, you can see that we can easily double the primary stability when this implant is placed using our implant motors. But I should warn you, when thinking about the insertion torque of this implant to others, there are condensing design implants, and the studies of condensation effects on peri-implant bone demonstrate several things. First, that high condensation will increase the density but weaken the bone, and it does not improve primary stability, nor will it improve secondary stability. It is associated also with bone resorption and demonstrable crestal bone loss. This has been shown in at least 2 different types of animal models at multiple levels. So when we think about gaining primary stability, we want to walk this careful line between managing bone carefully, the bone care concept, and aggressively managing with bone to gain a tactile sensation of primary stability that may exceed the capacity of bone to heal well. So bone care is a clinical approach to assuring dental implant excellence. Bone care requires assurance of primary stability without causing undue damage to bone tissue. Bone care requires assurance of secondary stability that is wholly dependent on rapid osteogenesis. And bone care requires that the lifelong tissue responses to an implant will favor the positive remodeling of bone in the face of mechanical and inflammatory challenges. Well, thank you very much for your attention. I hope you'll consider our thoughts about bone care in your practice on a daily basis, and I wish you the best of luck to you and your patients with your implant therapy.